We all know Canada is famous for its universal healthcare system. Canadians don't pay out of pocket for hospital or doctor visits, but few realize the system is nearing a breaking point. Wait times keep rising, doctor shortages grow. Citizens can't access the care they need. In this video, we'll analyze the root causes of Canada's healthcare crisis, and we'll discuss potential solutions before it's too late to save healthcare for all Canadians. Could Canada's world-renowned healthcare system collapse in our lifetime? Imagine needing emergency surgery and getting put on a 5-year waiting list, or calling 911 for your aging parent's heart attack, but no ambulance has come. In this video, I'll reveal the perfect storm of problems plaguing Canadian healthcare, while most of us remain unaware. Through aging demographics, staff burnout, lack of national coordination, and more, our system edges towards a breaking point. Stick around as we analyze root causes and discuss solutions so you can decide whether it's time to stand up for healthcare and stem this crisis tide. But before we continue, we would like you guys to subscribe to the channel, like this video, and hit the notification bell so you don't miss out on any amazing and entertaining content. First, Canada's aging population is placing unsustainable pressure on healthcare. As the baby boomer generation moves into old age, demand for services expands rapidly. From 2018 to 2040, seniors will make up 23% of Canada's population, up from 16%. With this epic demographic shift comes a towering increase in age-related conditions. Heart disease, cancer, dementia, diabetes, you name it. Managing these chronic diseases over decades costs the system hugely in doctor visits, procedures, hospital stays, tests, drugs, and more. They stay in hospital twice as long as younger patients on average, too. No wonder Canada's emergency rooms face dangerous overcrowding. We simply lack capacity for this silver tsunami of older, sicker patients flooding the system all at once. Surgeries and specialist appointments get postponed for months due to lack of beds, or time and practitioners. Ironically, the number of hospital beds per capita has actually decreased over past decades, just as patient volumes spike. Clearly, better long-term planning around infrastructure and staffing ratios is needed to handle this dramatic demographic swing. We must expand senior care resources rapidly or risk healthcare access declining for all ages. Ignoring systematic gaps just lets problems fester into crises down the road. For example, long-term care facilities and at-home care could alleviate pressure on crowded hospitals. Many seniors occupy acute beds while awaiting discharge to more appropriate settings. Expanding retirement and nursing homes would ease this gridlock. Likewise, providing more at-home supports like meal delivery, nursing visits, and telehealth could also keep independent seniors out of hospital. While we absolutely must care for aging Canadians who built this country, the system clearly needs 21st century recalibration. Healthcare designed for the 1970s looks woefully outdated, serving seniors in the 2030s. The scale of change required means we need to start planning now before demographics overwhelm. The second major driver of Canada's healthcare crisis is glaring shortages of key staff, nurses, and doctors. While an aging population means more patients needing care, overworked clinicians are burning out fast. These shortages leave remaining nurses and doctors handling unsustainably high caseloads. This fuels more fatigue and resignations in a vicious cycle. For example, Canada could be short 78,000 physicians by 2031 and 117,600 nurses by 2030. Nurses who remain handle endless overtime and unsafely high patient ratios. A 2022 report from the Canadian Federation of Nurses Unions found that 94% of nurse respondents showed signs of burnout, and over half wanted to leave their current job. These shortages hit some regions and specialities harder than others, too. Rural, remote, and Indigenous communities struggle to recruit and retain nurses compared to urban hospitals. Likewise, specialities seeing high burnout like emergency, oncology, and palliative care scramble to fill gaps with temp agency nurses. They cite heavy patient loads and lack of work-life balance as prime reasons for wanting to cut back hours or quit entirely. No surprise then that wait times for diagnostic tests, mental health services, and routine surgeries keep rising. Clearly, provincial governments need to act swiftly, expanding education and retention initiatives before staffing implodes further. The current nursing facility shortage blocks expanding student seats. We need financial incentives attracting more nurse educators to open bottleneck training pipelines. Likewise, medical college quotas could preferentially admit more primary care trainees over specialists more likely to burn out. Bottlenecks here lead desperate communities to recruit foreign-trained doctors with little support. Ensuring adequate doctors and nurses now prevents crises later. We also need better clinician mental health and workplace culture supports stat. Evidence shows interventions like wellness committees, flexible scheduling, peer mentoring, and reduced admin burdens prevent resignations. Investing in the staff serving patients seems the wisest healthcare investment of all. The COVID-19 pandemic has severely aggravated Canada's straining healthcare system. At infection peaks, hospitals overflowed with severe cases while trying to protect non-COVID patients and staff. Exhausted healthcare teams skipped vacations working around the clock for months, risking their own health on the front lines. Many hospitals suspended elective surgeries, screenings, and transferred patients to free beds for critical pandemic response. All oncology patients had treatment delayed during first pandemic waves. Caring for acute COVID crisis left some chronic disease management by the wayside. While public health measures like lockdowns and distancing eased immediate COVID patient influx as vaccination rolled out, pandemic fallout still handicaps the health system function today through care delays and backlogs. For example, delayed cancer screenings and surgeries could have devastating consequences if tumors spread undiagnosed. Researchers estimate that the pandemic could lead to 21,247, or 2% more cancer deaths in Canada in 2020 to 2030. Pandemic backlogs also continue flooding primary and community care. Clearing these waits could take years, even running practices around the clock. Patients deteriorate from manageable conditions going undetected so long and flood emergency departments instead, like seniors with uncontrolled diabetes ending up in hyperglycemic crisis when blood sugar rockets unchecked for 18 months isolated at home. The healthcare costs and complication cascades down the road look staggering. Mental health disruptions also concern experts deeply. Almost 1 in 7 Canadians now show symptoms of clinical anxiety or depression in surveys. Children and teenagers seem especially impacted by school and social life interruptions, worsening developmental disorders. Yet, already scarce mental health services have become even less accessible, with prolonged underfunding and long wait lists. Experts worry vulnerable Canadians who needed support through social isolation, job losses, and grief could tragically slip through the cracks, leading to substance use, chronic conditions, or crisis situations. The pressures facing Canadian healthcare predate and will outlive COVID-19. An aging population, doctor shortages, ER overcrowding, and mental health service gaps plagued the system before lockdowns began. But the pandemic has painfully exposed system vulnerabilities at a scale we can no longer ignore. It has shattered assumptions that healthcare could continue limping along the same worn path. While public healthcare struggles, more Canadians are turning to private options despite higher costs. These run the gamut from employer medical benefits to concierge care clinics to U.S. medical tourism. Patients value the flexibility of seeing specialists quickly and avoiding lengthy public wait times. Experts estimate over 60,000 Canadians traveled abroad for treatment in 2016. Literal medical refugees fleeing a system failing to meet basic health needs. Is this the kind of two-tiered healthcare system we want? High-quality care for those who can pay more while the public system crumbles? Canadians value healthcare equity in principle. Yet without better resourcing for the public system, private paid care will flourish. Another significant contributor to Canada's healthcare funding crisis is inefficient allocation of current resources. Provincial health budgets devote the lion's share of funds to hospitals and physician salaries. Yet many patients with manageable conditions end up at expensive emergency rooms, precisely due to lack of alternative options. Investing earlier in pharmacists, nurses, nutrition programs, and preventative care makes sound economic sense. Complications cost far more down the road than controlled maintenance does up front. Likewise, health regions with older average populations often receive lower funding per senior patient compared to districts with younger demographics. Rural and remote community healthcare also tends to be under-prioritized and understaffed relative to urban hospital expansion. Funneling more dollars towards these high-need areas earlier could reduce strain on urban hospitals later as patients deteriorate without local care. The truth is, healthcare funds don't always flow where they'll make the biggest impact. Historical line items get funded year over year despite evolving community needs. Health system leaders acknowledge existing incentive structures that reward volume of scans and surgeries over health outcomes must realign towards value. Shouldn't we analyze where limited taxpayer funds will relieve bottlenecks best? For example, Denmark funds most of its healthcare services through regional and municipal taxation, but municipalities have flexibility allocating resources innovatively. One town may invest in prevention programs tailored to an aging suburb's needs versus an urban youth campus. This decentralized flexibility within centralized strategy could inspire Canadian healthcare reform. Ultimately, Canadians fund universal health care through taxes to receive appropriate care when and where required. Doesn't that implicitly include administering said system in the most economical and equitable manner feasible as responsible stewards? We owe it to both unwell Canadians and healthy taxpayers to address these allocation inefficiencies in Canada's healthcare spending. Unlike European countries with government-administered national health services, Canada has a decentralized single-payer public insurance model. In simple terms, each province and territory heads its own healthcare system independently. They set unique budgets, policies, pay schedules, and approach negotiations with unions and industry. While the Federal Canada Health Act provides overarching guidance on adhering to principles like universality and portability, no unified national healthcare strategy exists currently. This decentralized model enabled local-level innovation and responsiveness historically, when healthcare infrastructure was simpler and less mobile. However, the lack of high-level vision and coordination across 13 distinct provincial and territorial healthcare systems hampers addressing today's national crisis. For example, Atlantic Canada trains more physicians per capita than the overall Canadian average. Yet Western provinces like Saskatchewan continue facing acute doctor shortages despite an overall physician surplus nationwide. Clearly, better clinician mobility pathways and forecasting is needed between regions facing surpluses and others dangerous shortfalls rather than each province guessing its future practitioner pool in isolation. Likewise, healthcare workers moving across provincial boundaries encounter barriers getting credentials recognized. A nurse licensed and practicing for years in Quebec currently needs to validate skills basically from scratch to work in Alberta. Red tape like this blocks clinician mobility between areas facing staff surpluses and shortages unnecessarily. Creating national collaborative licensure frameworks could alleviate bottlenecks within a couple of years versus over a decade provincially. Similarly, smaller provinces struggle negotiating effective bulk purchase rates for high-cost diagnostics equipment or drugs that larger provinces command. Federal coordination convening group purchasing organizations for everything from surgical gloves upwards could save billions in the long term. The pandemic's early days provide more evidence. With no centralized healthcare agency oversight, regional bodies scrambling independently for finite supplies of masks, testing materials, and vaccines pushed prices up and access down. A cohesive national strategy may have rallied global supply chains more quickly to equip frontline teams better. In reality, the sheer complexity of healthcare today requires systems-level thinking rather than solely regional. As medical technology advances, PAN's Canadian leadership on everything from health data management standards to gene therapy approvals makes increasing sense rather than piecemeal duplication only benefiting private interests. While decentralization enables local governance needed in this geographically vast nation, better nationwide coordination is clearly essential going forward. We need a coherent national blueprint to future-proof Canadian healthcare over the next 50 years. One that tackles big-picture challenges like health equity gaps or fast-tracks innovation benefiting all citizens equally. The post-pandemic rebuild offers the perfect window to align healthcare priorities nationally to optimize system functioning from St. John's to Victoria to Inuvik. Rising immigration levels also impact Canada's healthcare capacity. Back in the mid-1980s, Canada housed just 25.5 million residents in total. But flash forward to today in 2024, and we've sailed past a staggering 40 million people. Wait, it gets more mind-blowing. Experts predict Canada's population could reach over 50 million by 2040. Canada accepted over 492,984 immigrants in 2022 alone. This influx of immigrants negatively influences the healthcare demand. Recent arrivals tend to be younger on average and use less health services initially. Yet as they age, chronic disease patterns mirror native-born Canadians. In time, smoking, obesity, and high blood pressure manifest, increasing system pressures. More significantly, new immigrants experience unique health challenges that our healthcare infrastructure doesn't adequately address. For example, language barriers impede accessing services or following treatment plans. Concepts of preventive care and screening also differ by culture, affecting usage patterns. Communicable tropical diseases from an immigrant's country of origin may have doctors scratching heads too. Consider poorly controlled diabetes or infectious hepatitis presenting at ER after limited primary care. Or overseas medications interacting with Canadian prescriptions since electronic records don't cross over borders. So while Canada welcomes over 400,000 newcomers annually, the country outright blocks their healthcare credentials and skills from being deployed to strengthen the understaffed hospitals. It's totally counterintuitive and counterproductive. The frustrating end results? Predictable but tragic. ER closures are becoming routine. Delayed life-saving cancer surgeries push mortality rates higher than peer nations. And healthcare staff shortages leave every hospital overcapacity warning lights blinking. While the scale of healthcare challenges today looks daunting, solutions exist if Canada summons the foresight and willpower. With an aging population, overburdened workforce, infrastructure deficits, and regional fragmentation, our system cracks under immense stress as demand outpaces capacity dangerously. And this video only highlighted some key pressure points, not even addressing pharmaceutical costs, dental care gaps, health equity divides across geography and ethnicity. What gives you hope seeing the depth of challenges covered today? Which solutions discussed seem like the most practical first steps towards a robust made-in-Canada health system? Share your thoughts in the comments below. Make sure you subscribe and smash that notification bell to catch future videos. And thanks everyone for watching, and see you again soon.